Hello, everyone. Welcome. My name is Wendy Xie, and I am one of the project managers at the National Collaborating Center for Infectious Diseases. And I would like to welcome you to this webinar where we will be having a discussion about the ongoing global outbreaks of mpox and what this means for Canadian public health. First, I would like to mention that I am joining this webinar from the unceded lands of the Anishinaabe Algonquin Nation. And I would also like to acknowledge that the National Collaborating Center for Infectious Diseases, or NCCID, is hosted at the University of Manitoba, which is situated on the ancestral lands of the Anishinaabe, Anishinaabeg, Dakota, Dene, Nehithawak, and Aninwak nations. It is also in the heart of the Métis Nation. At NCCID, we strive to honor the lands and their original caretakers in our work. We acknowledge that we are on Treaty 1 land, and we recognize that this and other treaties have been implemented as a part of the process of colonization intended to benefit some while harming others. And we are committed to working with our partners towards reconciliation and justice. So before we begin, just a few housekeeping notes. We'll be using the chat tab only for communication with attendees, so please check there for any updates. And if you're experiencing any technical issues with Zoom, please email us at nccid@umanitoba.ca, and we'll try to get that sorted out for you as soon as possible. Please leave any questions you have for the speakers in the Q&A tab, and we will try to get through as many of those as possible after the presentations. And just a reminder that you can give a thumbs up to any questions in the Q&A tab to push them up in priority. And we do have a couple of questions coming in from participants at the time of registration, and we'll also try our best to get through some of those as well. And finally, a recording of this webinar will be available on the NCCID website under the webcasts tab shortly after the event. And now I would like to introduce our two speakers for today. First is Dr. Daryl Tan, who is an infectious diseases physician and clinician scientist at St. Michael's Hospital, where he leads the Options Collaboratory in HIV and STI treatment and prevention science. He is also an associate professor at in the Department of Medicine and Institute of Health Policy Management and Evaluation at the University of Toronto, with a cross-appointment in the Institute of Medical Science. His research focuses on clinical trials and implementation science in the areas of HIV prevention, HIV treatment, and sexually transmitted infections. Dr. Tan holds a Tier 2 Canada Research Chair in HIV Prevention and STIs, is co-lead of the HIV Prevention Core of the CIHR Canadian HIV Trials Network, and is a member of the Governing Council of the International AIDS Society. Our second speaker is Joshua Montroy, who is a scientific project coordinator for the NACI Secretariat within the Infectious Diseases and Vaccine Programs branch at the Public Health Agency of Canada. NACI, of course, is the National Advisory Committee on Immunization. Josh holds a master's degree in epidemiology and community medicine from the University of Ottawa, where he trained with the Center for Transfusion Research. So thank you both for being so generous with your time and joining us today. I will first pass the mic to Daryl.
Okay, thank you so much for that introduction, Wendy, and thank you everybody for being here today. I'm going to share my screen and put it into hopefully the correct presenter mode. And Wendy, you can give me a thumbs up if we're good to proceed. Looks correct.
I think you need to swap to the other view.
Okay. Are we good?
Yeah, that looks perfect. Thank you.
Excellent. Well, thanks so much for the warm introduction. Thanks so much, everybody, for being here. In particular, thank you, Wendy, for the land acknowledgement that you started with. I'm calling in today from the traditional territories of the Mississaugas of the Credit, the Haudenosaunee, Anishinaabe, Huron-Wendat, and Chippewa people. And I'd like to start many of the talks that I've done on this topic of mpox with this image that reminds us of the links between the oppression of Indigenous people on this land with a very closely related virus, smallpox. It's being illustrated in this drawing here with the suffering that's gone on with mpox in a different but also important equity-seeking group of sexual minority men primarily in the last couple of years. Here is a depiction of smallpox literally being weaponized knowingly by officers of the English Army at the time, famously the English officer Sir Geoffrey Amherst, after whom Adadagan Street in downtown Montreal, in the heart of the gay village where mpox was first detected in this country just a couple of years ago, that street was renamed because it had previously been named after that individual. And I think that just the links between the ongoing legacy of colonization and the ongoing struggles that relate to health inequities as well faced by equity-seeking groups today are really profound. So we all know that in just the last few weeks, interest in mpox globally has really taken off, in part because the WHO once again declared this agent a public health emergency of international concern. And what's behind that is, of course, that since 2022, this infection that had previously been geographically isolated and inequitably ignored in Central and West Africa has really become a global epidemic. And you can see the entire hemisphere of the Americas has been heavily affected by mpox, and that continues to be the case. But what's really driven the concern, as you all know, in recent weeks, has been the explosion of cases, primarily in new parts of Africa. So this is an epi curve for much of 2024, in which you can see that overwhelmingly cases have been primarily reported from the DRC. And in the more recent bars, you can see different colors, different countries starting to be represented, in particular, Burundi, a close neighbor of DRC. And concerningly, it has been detected now in more and more countries in Africa where it had never been detected before. Here is a figure from a beautiful paper that was just published a few weeks ago in Nature Medicine, showing that there have been, if we zero in on DRC, a large number of cases, particularly detected in the east part of the country. That's the large burgundy circle on the right-hand side of the map of DRC there. And final genetic analyses have demonstrated that these have really clustered together in a way that's distinct from prior isolates from other parts of the country or other points in time. And that's what's led investigators to propose that we now consider this new clade of the virus, a new clade, a subclade, clade 1b. In the next slide, you'll see that clade 1b has really been reaching now as far east as the Indian Ocean. So it's reached Burundi, Rwanda, Uganda, Kenya, and in this graphic, you can also see the extent of clade 1a extending through much of Central Africa, and then many parts of, all over the continent that continue to be affected by the same clade that affects most of the rest of the world at this time, which is clade 2, shown here in yellow. And that is the clade that's to date we have seen in Canada. The epi of this virus is really quite interesting, as I'm sure you all know, that despite its name, it is not thought to be natively a virus that infects primates, although that can occur. The main host is thought to be various rodents. And historically, it had been a zoonotic infection, such that primarily young children and others who were in close contact in more rural parts of countries like DRC, Nigeria, and others had become infected, unfortunately. What we had started to see in the last several years, though, is outbreaks beginning with a very large outbreak in Nigeria in 2017, in which there was more sustained human-to-human transmission, not only within households, but also notably through sexual transmission. That's, of course, what has driven the global outbreak that we've seen since 2022, and specifically transmission has been occurring in dense networks of gay, bisexual, and other men who have sex with men, primarily. Roughly, 98, 99% of cases in most settings have been concentrated in that population. Of concern, what we're seeing in Africa in the last several months seems to be that there has also been sustained human-to-human sexual transmission in heterosexual networks. And in fact, some of the reports from the eastern part of DRC, from the paper that I briefly showed you a moment ago, reported that there was a disproportionate number of cases in female sex workers in a location where there was a lot of mobility in the population and many transnational populations moving in and out of this mining area, such that this was likely how the infection was spread so easily to the other countries in East and Central Africa that we just mentioned. I think we still need to learn a lot more about the ongoing epidemiology of this transmission. The data capture and reporting has, for many obvious reasons, been a little bit more restricted in terms of what continues to go on in Africa at this time. And there's the potential, of course, for things to change elsewhere, although so far in Canada, we've continued to see the same pattern. That pattern is represented nicely in these data, and I apologize, I'm showing you Ontario-specific data as opposed to Canadian national data up until about a month ago, but I do think that this is informative because it does represent a large proportion of the cases that we've seen in this country. And you can see that there was a large rise in cases over the course of the later weeks of the summer, represented by the blue bars on the left here. And on the right-hand side, you can see just a very high-level epi summary of some of the key demographic characteristics, once again, overwhelmingly concentrated in people assigned male sex at birth, overwhelmingly gay, bisexual, and other men who have sex with men. And the age distribution tends to be in the mid-decades of life, so you can see 39% or so in people aged 30 to 39, et cetera. Of great importance, we're seeing that many of the cases we've seen have occurred in people despite having had 1 or even 2 doses of the vaccine that we'll speak about during today's webinar. A quarter of cases in Ontario having had 1 dose of Imvamune and about 15% having had 2. So that's a really important observation. We'll speak a little bit more about the implications of that for clinical care as well as for ongoing use of the vaccine moving forward. Now, in the next series of slides, I'm going to show you some images of what this infection actually presents as. So they become a little bit more graphic. So just so that you're forewarned of that, I want to tell you a little bit about a reminder of what mpox actually looks like clinically. And I'm going to start with some slides that illustrate the classic presentation that we have been seeing for the last couple of years. Again, it's been largely transmitted through sexual activity, dense sexual networks of GBM, gay, bisexual, other men who have sex with men who have new partners. And therefore, the initial places at which people often have symptoms is at the site of inoculation. Hence, we're seeing lesions in the mouth, in the oral cavity, on the genitalia, in the anal area. Notably, you can also, of course, have symptoms deep to what's being depicted in these images. So we do see people presenting with a sore throat or a pharyngitis picture, many people presenting with proctitis. And importantly, some of this has been really, really severe, causing a lot of suffering, people describing the feeling as though they're passing razor blades when they try to go to the bathroom, people saying they're unable to walk, unable to sit because of the proctitis symptoms, really potentially quite debilitating. There is a sequence, characteristically, in which the lesions evolve, though. They don't initially start out looking like this, although this is a pretty classic set of images of what mpox lesions do ultimately look like, but they can often begin as a fairly innocuous papule, just a red bump that evolves into a pustule that then has this central kind of ulceration or central depression or umbilication. Here it's depicted as this kind of darker purplish that you can see in the center of these lesions, retaining that raised whitish edge. Many patients describe lesions as having, quote unquote, a black dot in the middle of it, and you can really appreciate in these images why that is. The next picture or set of pictures really just shows you some of that evolution. These 3 images were taken over the course of just 3 days. And you can see on the left how it kind of started as something more like a papule, but then quickly became a pustule with that central umbilication. In the next couple of days, this lesion would have further evolved into the image that you just saw on the previous slide. Accompanying the lesions, classically, many people will have a pretty pronounced lymphadenopathy, often in the neck and the groin because of the initial locations where the infection has been inoculated. And it really is quite striking. Sometimes you can see it across the room. These are all images, by the way, of people that I've had the privilege to care for who gave permission for these images to be used in medical education presentations. But you can literally see it across the room sometimes. You can certainly palpate it quite readily, and it really is markedly firmer than you would typically see in many other sexually transmitted infections, which might also present with lymphadenopathy in these regions. Accompanying these, you can also see characteristic constitutional symptoms, flu-like symptoms such as fever, rash, fever, headache, fatigue, pain all over, myalgias, and that can be a clue as well, although the sequence in which people have those initial skin lesions, lymphadenopathy, and constitutional symptoms varies. What tends to happen in almost all folks that we've seen, though, is that there can be a secondary wave of skin lesions that occurs after they've gotten over that initial flu-like illness, or at least after the initial lesions have become quite apparent. And these can pop up, A, all over the body, and B, in ways that do not necessarily look like those classic, if we can call them primary lesions. And these are images from taken from the same person within a 24-hour period. You can see a macule that you might hardly notice on the left. You can see a really classic-looking vesicle on the arm here, and then some pustules on the elbow over here. These were all present, in the same person within a similar amount of time. None of these really progressed to have that very characteristic appearance of the primary lesions that I showed you earlier. And I think it's really important for us to be aware of as clinicians, because it does mean that many things that a person might experience in the second, third, fourth weeks of their illness with mpox may look pretty innocuous. And many, many patients that I've had the privilege of caring for have said, oh, no, that's just an ingrown hair, that's just a pimple, I get those all the time. If I allow them to humor me and let me swab those later lesions just to check, almost every single time it has actually shown mpox virus to be present. So don't be fooled by the variation in secondary skin lesion morphology. Of course, there can also be unusual manifestations. When you see a lot of something, you'll see weird manifestations of it. Here is a case report that a colleague published of a case of esophagitis. We've had a small number of cases of pericarditis and myositis associated with mpox. So be on the lookout for unusual manifestations as well. And be aware that in the setting of folks with advanced HIV, unfortunately, outcomes can be much more dramatic than what I've just described. So here is a nice paper from last year showing stratification according to CD4 count on the left-hand panel, viral load on the right-hand panel, showing that the poorer those HIV-associated parameters are in someone living with HIV, the worse the outcomes. And you can see a non-trivial proportion of people who unfortunately actually succumbed to their mpox infection in the stratum with the lowest CD4 counts of less than 100. I'm going to show you another set of images that are really quite upsetting to look at. On the next slide, you can see this series of really severe lesions in those most advanced cases of people living with HIV who had mpox infection. You can only imagine the extent of pain and suffering that this has caused, and of course, in some cases, even leading to death. Certainly, bacterial superinfections are a concern when there's this many large lesions present. However, this is not to say that every person living with HIV who acquires mpox is going to have a bad outcome. Absolutely true that when folks have well-controlled HIV, as was the case in the majority of these reports summarized in this table here, folks tended to have outcomes similar to folks who were not living with HIV. And strikingly, across many of these GBM cohorts from around the world, the proportion of people living with HIV that were included in these case series of people with mpox infections was pretty constant, suggesting a pretty stable degree of sexual mixing between people living with HIV and not. I'm going to show you a little bit of data from a study that we did launched in 2022, looking at some of the virologic aspects of the infection. Essentially, what we did here was take data from 2 studies of 64 men that we cared for here in Toronto and modeled the number of days that it took before viral DNA was no longer detectable, defined as a cycle threshold value of equal to or greater than 35. And in the table here, you can see that number of days. It was greatest at over 4 weeks, 30 days as an average value in genital, buttock, or perianal skin. Again, that's the site of typically of inoculation where we would have first seen the lesions. But in other skin sites, such as the ones I just showed you pictures of, it easily took over 3 weeks, and in other sites, easily a couple of weeks before we could no longer detect the virus. Now, does that mean that it's necessarily infectious to other people for all of that time? I don't think we fully know the answer to that question, but the threshold that we used did correlate with viral replication studies that have been done by others in terms of this CT value. So it does suggest that there could be the potential for onward transmission, and certainly there's the potential for ongoing skin lesions popping up for weeks after someone first acquires this infection, unfortunately. We spoke earlier about the fact that many of the cases that we're seeing now in 2024 have included people who have had prior vaccine. And an important point to make is that, once again, the presentation may differ in that setting. So here are some images of a person who had mpox first appear on his body just a few days after getting a first dose of the vaccine. So he thought he was getting a dose of the vaccine kind of as pre-exposure prophylaxis, as a primary prevention intervention. In effect, it ended up being a form of secondary prevention for him. But the images here are really quite characteristic of the mildness of the lesions that we see in folks, many people who have had at least 1 dose of the vaccine. You can see that you could hardly distinguish this just from a benign pustule or folliculitis or just some macules that were non-specific and benign, but indeed these lesions swabbed positive. So a reminder that if you are trying to make the diagnosis of mpox, you can sample one of these characteristic sites, get a really vigorously collected specimen using a viral swab. Remember that those are the swab kits that look like this. A tube with some universal transport medium in it, and a swab that you can use to collect a sample from the pharynx, from the rectum, from a lesion. You need not necessarily puncture a lesion to get fluid out because there is some risk of auto-inoculation if you're not careful with the needle and puncture yourself by accident. Certainly, it would increase the yield if you have more fluid, but do collect the swabs quite vigorously, and remember that you can sample more than one site if you are not sure of the diagnosis and want to confirm it. Here's a little bit more information about the manifestations of mpox in folks who have either had past infection, which can rarely occur, or have had a complete course of vaccine. This was published last year in the Lancet IT, and you can see that overall, people who either had a reinfection or had a post-vaccine infection had a shorter course of illness and fewer lesions. And there's been a nice report just a few weeks ago in MMWR that I'll just show you at a very high level here, looking at many hundreds of individuals who had mpox despite being fully vaccinated in the United States. And if you just scan this huge list of different manifestations, you can see that virtually every single one was attenuated in the group of people who were fully vaccinated to a statistically and clinically significant degree. I won't read them all out, but I just want to draw your attention. The point is that the phenotype is milder. In fact, it can be so mild that folks can even have an asymptomatic or perhaps a polysymptomatic infection such that they may not realize this. We've certainly seen cases of mpox in people who clearly only have one contact, and that other contact reports basically feeling completely normal or minimally unwell. They may have had minor symptoms that they brushed off as something else, such as hemorrhoids, something like that. So really important to be aware of this unfortunate possibility. What can we do about it if someone has infection? Well, there is this antiviral drug that exists. It's called tecovirimat, and the way that it works is illustrated in this diagram over here. It binds to a viral protein that's common to orthopox viruses, but does not have an analog in mammals like ourselves, and hence this explains why empirically we've also observed it to be very, very tolerable. There's no off-target effects that we've seen. The dosing is 600 milligrams twice a day for 2 weeks, and this is what the tablets look like. They're 200 milligram capsules. And there is regulatory approval for the use of this drug by Health Canada based on animal efficacy data and human safety data. But a really important point to make is that we do not actually have data proving that it works in the context of human mpox infection. Nevertheless, in 2022, it has been used a fair bit, especially in folks who had more severe disease. We tried to capture our experience using this drug in some of our own research. This is a report that we presented in conference form so far, in which a large number of individuals either who received tecovirimat during the period shown in the yellow bars here, or did not receive it in the bottom panel, and we're counting the number of symptoms that people had over time. The darker the dot, the more symptoms. And key points to make in this is that include that, number one, everyone gets better over time, okay, whether or not they get the drug. Certainly the people who got the drug tended to be people who had more severe symptoms, but our follow-up of them was incomplete in many cases because many of these folks were not enrolled into studies that allowed us to see how quickly they got better. And the very fact that it was tending to be the more severe cases who got the drug in 2022 compared to those who did not means that any experience that we have is, of course, confounded by indication. What this really tells us is that we really do not know to what extent this drug does or doesn't help persons with mpox infection. We absolutely need to be doing clinical trials, and thankfully there are trials going on around the world. Here in Canada, we have the Platinum Can trial. Marina Klein from McGill University is our PI, but we have sites enrolling not only in Montreal, but also in Toronto at my own site, St. Michael's Hospital, at the Toronto General Hospital, in Vancouver, and anyone who has a person in one of those locations who has confirmed mpox or even suspected mpox infection, we highly encourage you to get in touch with the study. Here's our link, but you could also just Google mpox CTN, that's the Canadian HIV Trials Network, that's running the trial, in order to rapidly link a person to the trial. So I'll stop with just a couple of key points. This is what a classic mpox lesion looks like, but I hope I've shown you that the lesion appearance can be variable. It can certainly vary in the presence of vaccine or in the setting of advanced HIV. Remember, there are other manifestations to look out for: mucosal infection, severe lymphadenopathy, and flu-like symptoms. This is what you're going to use to make the diagnosis, not a bacterial swab. And although this drug exists, we really do not know whether it works, and there is clinical equipoise to be continuing clinical trials. So here in Canada, Platinum Can, you can just Google mpox CTN. In Ontario, there are special access program ways to access the drug as well that are going to be jurisdiction specific. And in the next slide, I think Joshua is going to tell us all you ever wanted to know about the vaccine. So I won't comment very much on that. I do have many people to thank for all of the work that we've been doing on mpox, our funders and our research participants especially, and I'll end my comments here. Thanks so much.
Thank you so much, Daryl, for that presentation. Just a reminder to participants, if you have any questions along the way, to please drop them in the Q&A. And now I will ask Josh to please share his slides.
Okay, thank you, Wendy. Can I get a thumbs up here that you can see these in presentation mode? Perfect. Okay, good morning or afternoon, everybody. Thank you for coming today. My name is Joshua Montroy, and I'm an epidemiologist and scientific project coordinator with the NACI Secretariat at the Public Health Agency of Canada. So I'm going to be discussing today the NACI guidance on the use of Imvamune in the context of a routine immunization program. So a brief outline of my presentation today. I'm going to be going through the context of the updated NACI recommendations, followed by a brief summary of the evidence, or some of the evidence, that was available at the time of NACI review and that NACI discussed. And then, of course, I'll follow that by showing the new updated NACI recommendations, with a bit of a focus on what is new or different in these recommendations compared to the previous outbreak guidance. So a quick look at the previous NACI guidance, which was issued in the context of the outgoing outbreak in 2022. So NACI recommended, in the context of this active outbreak, that immunization using the Imvamune vaccine should be offered to individuals at highest risk of mpox. So this included men who have sex with men, and individuals who have sex with men who have sex with men, and who meet at least one of the following criteria. So having 2 or more sexual partners, or being in a relationship where at least one of the partners has other sexual partners, having had a confirmed sexually transmitted infection acquired in the last year, or engaging in sexual contact in sex on-premises venues. Other individuals eligible included individuals self-identifying or individuals who identify as sex workers, regardless of their self-identified sex and gender, and staff or volunteers in sex on-premises venues where workers may have contact with fomites potentially contaminated with mpox. And individuals with a prior documented history of mpox infection were not recommended for vaccination. So now I know this graph looks much different today, and we saw some current Ontario epi in Dr. Tan's presentation. But at the time of NACI review, this is what the mpox epidemiology looked like in Canada. And there had been a dramatic shift over the course of about a year. So this graph shows confirmed mpox cases in Canada as of September 2023. So it's about a year out of date now. But we can see that the incidence of mpox cases had decreased quite dramatically from the peak in the summer of 2022, which is when the previous NACI guidance was released. And this is the two NACI guidance documents that were released are indicated here on this graph by the yellow stars. So this dramatic shift in epidemiology was one of the factors that triggered updated NACI guidance. Another key trigger for the updated NACI guidance was in the fall of 2023, so last year. Both the US and the UK issued recommendations on the use of Imvamune for use in a routine mpox immunization program, so rather than recommendations in outbreak settings. The ACIP from the US, which is essentially the NACI equivalent south of the border, recommended that 2 doses of Jynneos, which it's a little confusing, but it's the license name for Imvamune in the US, so it's the same thing. So 2 doses of Jynneos be given to individuals 18 years of age and up at risk for mpox, with the risk factors identified looking quite similar to what we saw just a couple seconds ago with the previous NACI recommendations. So this included GBMSM, transgender, or non-binary people who in the past 6 months had at least one of the following, so a new diagnosis of at least one STI, more than one sexual partner, sex at a commercial venue, or sex in association with a large public event. So also sexual partners of persons with these risks and persons who anticipate experiencing any of these scenarios were also recommended for vaccination. So the ACIP noted that these recommendations were interim and plan to revisit them in 2 to 3 years. And in the UK, the JCVI, which again is the UK equivalent of NACI, recommended that pre-exposure vaccination should target GBMSM, who are at a highest risk of exposure to mpox, to be identified via sexual health services using markers of high-risk behavior similar to those used to assess eligibility for HIV pre-exposure prophylaxis, but applying these criteria regardless of actual HIV status. So these risk criteria pretty similar to what the ACIP had and what NACI recommended. It's individuals with a recent history of multiple sex partners, participating in group sex, attending sex on premises venues, or a proxy marker such as bacterial STI in the past year. So I'll note here that neither of these advisory bodies recommended a 3rd dose or a booster dose in any populations at the time. So we can see that these recommendations are pretty similar. There's a couple of slight differences, but they're generally quite consistent and quite similar. So with these triggers spurring the need for updated guidance, the primary research question addressed by NACI was, should NACI extend the current recommendation on pre-exposure vaccination for mpox to use in a routine program to be reevaluated once additional evidence emerges? So for this question, NACI considered guidance from the US and the UK that we just saw to streamline their guidance on the use of Imvamune for a routine immunization program, and leveraged the ACIP guidance when developing the evidence to decision framework to inform this guidance. So I'm not going to go through this evidence to decision framework in totality. It would take way too much time, but I will touch on many of the domains at a very high level and what some of the conclusions were with those domains. There was also a collaboration between NACI and the Committee to Advise on Tropical Medicine and Travel, or CATMAT, as the NACI guidance does include focused travel-related guidance. And finally, individuals considered at highest risk of mpox, as per the previous NACI guidance that we saw in one of the first couple of slides, was applied here as well. So the definition remained consistent. So I'm going to go through some of the data that NACI looked at when making these recommendations over the next couple of slides. First, we'll look at the clinical data supporting the use of Imvamune for the prevention of mpox. So this is evidence that was available at the time of NACI review. So there has been new evidence since, but the evidence that I'm showing here was evidence available at the time that the recommendations were made. And at this time, evidence was limited to real-world vaccine effectiveness, or VE, observational studies. And at the time of review, there were 10 studies available, including 2 from Canada, which reported on the VE of a single dose of Imvamune against mpox infection. And 3 of these studies also reported on the VE of a complete 2-dose series. So again, there's some additional data available, but at the time, this is what NACI had available to them to look at to make decisions. So a single dose VE ranged from 36% to 86%, and VE with the complete 2-dose schedule ranged from 66 to 89%. It's important to note here that the risk of bias in each of these individual studies was assessed by the NACI Secretariat, and there were some concerns identified, including some serious concerns regarding risks of confounding and the measurement of the outcomes in the studies. And about half of the studies, so 5 of the 10, were found to be at a serious risk of bias. So with these caveats in mind, the conclusion here was that VE with Imvamune was quite high, but the findings from the individual studies should be interpreted with caution. However, the clinical benefits of vaccination do appear to be quite large. And I will note here quickly that given the current environment, this data was all against mpox clade 2 infections. So looking at the Canadian safety surveillance data, the vaccine was overall quite safe, with the most frequent adverse event after either dose being injection site reactions, with about 60% of vaccinees experiencing these reactions. I'll also note that the Canadian safety surveillance data was generally pretty consistent with what was observed globally. Less than 10% of individuals receiving the vaccine developed a new health event within 7 days of receiving the vaccine, and less than 5% of these events prevented or stopped normal activities or required an emergency department visit or hospitalization. Systemic reactions were reported less frequently after the second dose compared to after the first dose. And also there were no cases of myocarditis or pericarditis reported by any of the participants or any of the survey respondents, which was a theoretical concern given the target population of the vaccination campaigns. So NACI also reviewed considerations related to the resources required for implementation of a routine program, so aka like the cost of the vaccine and the cost of the vaccination program. Imvamune doses are procured federally and are only available to provinces and territories as a federally procured supply, since this vaccine is stockpiled for emergency preparedness. But additional supply was procured on behalf of provinces and territories for their public health use for the prevention of mpox. There was no formal cost effectiveness analysis conducted in the Canadian context, so this was not a piece considered by NACI, but program costs would likely be different in a non-outbreak setting. For example, we would generally be moving away from primarily supplying vaccination via pop-up clinics. And a routine program is generally expected to be a better use of resources compared to the high costs associated with program implementation during an active outbreak. There was some cost effectiveness modeling from the UK, which modeled routine and reactive mpox vaccination programs and showed that all programs, regardless of how they were deployed, are expected to be cost saving compared to no vaccination. So some important equity considerations discussed by NACI include that people from GBMSM communities are primarily the ones affected by mpox. The GBMSM community historically and currently face stigma and discrimination, resulting in barriers to healthcare, employment, housing, etc. Some members of GBMSM communities report that contracting mpox would be catastrophic due to the 21+ day isolation periods, impacting their ability to maintain employment and afford necessities. For sex workers, many of these individuals may have similar risk to GBMSM due to overlapping communities and activities. People living with chronic diseases, for example, those living with uncontrolled HIV or chronic immunosuppressing conditions, are a population of interest, as it is possible that they may have a decreased vaccine responsiveness. And finally, people who are pregnant may be at an increased risk of severe disease and fetal demise from an active mpox infection. So overall, NACI determined that a routine program would increase public health equity in Canada. NACI also reviewed feasibility and acceptability considerations when implementing a routine program. At the time, provinces and territories were all continuing to offer pre-exposure vaccination to at-risk groups. During the summer of 2022, NACI engaged with impacted communities. So for example, those organizations representing GBMSM and/or female sex workers for consultation, and the communities were found to generally be positive towards vaccination. New evidence, again, this was new at the time of NACI review, from a study surveying mpox vaccine uptake among a group of sexual and gender minority young adults, found that roughly 50% of sexual and gender minorities had received at least their first dose of the mpox vaccine. However, only roughly 25% of participants had completed their recommended 2-dose schedule. There's some recently available evidence from Ontario suggesting that only roughly 1/3 of vaccine recipients have completed their 2-dose schedule. Factors impacting uptake were found to be socioeconomic stability and fear of social rejection due to disease acquisition. And it was recommended that mpox vaccine programs use strategies tailored to the needs of sexual and gender minorities. Ongoing acceptability challenges also included the possibility that equity-deserving communities may have distrust in government and healthcare institutions due to past and current marginalization. But overall, NACI determined that a routine program is acceptable from the perspective of stakeholders and is also feasible to implement. Okay, so moving on to the actual NACI recommendations. First, NACI recommends that individuals at high risk of mpox should receive 2 doses of Imvamune administered at least 28 days apart. And this is a strong NACI recommendation. Doses should be administered via subcutaneous injection. Dose-sparing strategies involving intradermal administration are not recommended in the context of routine immunization. So anything on this slide or the next couple of slides that's bolded or underlined has to do with changes, new additions, or modifications from the previous guidance. So those who have started a primary series with Imvamune, in whom more than 28 days has passed without a receipt of the second dose, should receive the second dose, and this is regardless of the time since receipt of the first dose. Those who have previously received a smallpox vaccination and are recommended to receive Imvamune based on the risk factors for mpox should also receive a 2-dose series with respecting the minimum interval of at least 28 days. Imvamune vaccination can be given concurrently or at any time before or after any other live or non-live vaccines. At this time, Imvamune is not routinely recommended for healthcare workers, including those serving populations at a high risk of mpox, with the exception of post-exposure vaccination. NACI guidance on the use of Imvamune in the context of a routine immunization program should be considered interim and will be reevaluated once additional evidence emerges. So here are the listed criteria for high risk. And as I mentioned earlier, it's remained fairly consistent with the previous guidance. So it's MSM who have more than one sexual partner or are in a relationship where at least one of the partners has other sexual partners, or have had a confirmed sexually transmitted infection in the last year, or have engaged in sexual contact in sex on-premises venues. Other individuals eligible include sexual partners of individuals who meet the criteria above, sex workers regardless of gender, sex assigned at birth, or sexual orientation, staff or volunteers in sex on-premises venues where workers may have contact with fomites. And the new additions here are bullets 5 and 6. So those who engage in sex tourism, regardless of gender, sex assigned at birth, or sexual orientation, and individuals who anticipate experiencing any of the above scenarios. So some additional considerations that I'll go through relatively quickly. So these are from the NACI statement. Based on available evidence, which is limited for other immunocompromised populations, unvaccinated individuals with uncontrolled HIV infection are considered at a higher risk for severe mpox. Numerous studies are reporting that 2 doses of Imvamune are effective at preventing mpox and associated outcomes, including amongst additionals living with HIV infection. Given the lack of evidence on the benefits and risks, NACI is not issuing recommendations on additional doses of Imvamune within the context of a routine program at this time. So far, there is no evidence to suggest that additional doses of Imvamune are needed for individuals at high risk in community settings, including those who are immunocompromised. Evidence will continue to be reviewed on the topic as it becomes available. And finally, evidence is limited in pediatric populations, and the current licensed indication of Imvamune is for people 18 years of age and up. However, off-label use in pediatric populations may be considered for both pre- and post-exposure prophylaxis for those meeting the high-risk criteria. Similar to the previous guidance, vaccination is not recommended for individuals who have had mpox, and healthcare professionals should use clinical judgment when considering vaccinating individuals who have a history of mpox infection. There are limited data regarding Imvamune use among specific populations, for example, immunocompromised individuals or individuals who are pregnant and or breastfeeding. But these individuals should be offered Imvamune if vaccination is recommended based on the high-risk criteria. And individuals at high risk of mpox and planning to travel internationally should consult with their healthcare provider on vaccination at least 4 to 6 weeks prior to travel, and particularly those traveling to countries with ongoing mpox transmission. So just in the interest of time, I'm going to skip this slide. It's just reiterating the NACI guidance on post-exposure prophylaxis or post-exposure vaccination. This is nothing here has changed since the previous NACI guidance, so we can revisit if people have questions, but I'm going to skip it for now. And finally, at this time, Imvamune is not routinely recommended for healthcare workers, including those serving populations at high risk of mpox, with the exception of post-exposure vaccination. NACI will continue to monitor emerging evidence and update guidance on Imvamune for pre- and post-exposure vaccination, mpox as warranted. This will include monitoring the duration of protection following a two-dose schedule, or the duration of protection following an mpox infection. And this will inform the need for additional doses or vaccination in those with a previous infection. That's the last slide here, showing the research priorities identified for NACI. I won't read through these, but essentially, number one priority is determining the duration of protection offered by either a two-dose schedule or a previous mpox infection. And finally, just an acknowledgement of the NACI mpox working group and my colleagues at FAC. Thank you.
Great. Thank you so much, Joshua and Daryl, for your presentations. Very informative, excellent presentations. I think we'll take a few minutes to answer some questions. Thank you, Daryl, for going through some of the questions already. I believe you answered 3. So please take a look through those in case they match up with a question that you already have. I do have some additional questions that came in at the time of registration, so I'll go through those for now. So I think first, of high interest for everybody, I think, is the question of whether or not you foresee mpox, either clade 1 or what we currently are observing, clade 2, being endemic, becoming endemic to Canada. And I believe Josh already mentioned this a little bit close to the end of your presentation, that one of the research priorities is to better understand protective thresholds. The question also wanted to ask about the expected long-term protection. So maybe I'll pass over the endemic question to Daryl first.
Sure, thanks, Wendy, and thanks to whoever asked that question. I think it's a really challenging, well, in some ways it's challenging, in some ways it's not, because I think that the last 2 years have already told us the answer is yes. This is not an infection, unfortunately, where we would expect it to be eradicable, if I can use that word. It has animal reservoirs that are not even fully understood, that exist all over the planet. And we've seen empirically in the last couple of years that even when it has been relatively contained to a specific sexual network really, that's fairly dense, it has persisted, and the presence of minimally symptomatic, asymptomatic infection, asymptomatic transmission, the fact that we do not have complete immunity conferred even by 2 doses of this existing vaccine, I think all of those things tell us that it has already become endemic, perhaps in specific populations, and we would not expect it to be something that we can eradicate, unfortunately. So mpox is here to stay.
Thank you, Daryl. And then really quickly, Joshua, again, I believe you already kind of answered the question related to long-term protection of the vaccine. And Daryl actually provided some evidence for that as well. Am I correct in saying that right now it truly is just a research priority and we don't have a lot of understanding for the longevity of protection provided by the vaccine?
Yeah, that's exactly it, Wendy. I'd say that that's an accurate statement right now. It's a developing area of research. Data continues to come out showing antibody waning or immune response waning over time, but what that actually means is pretty unclear right now. So how that correlates to actual protection is not quite clear, but hopefully over the course of the next several months, we'll have a bit more clarity on the duration of protection.
Perfect. Thank you, Joshua. Another question came in from Janice a moment ago related to vaccines, so we'll just jump over there quickly. Janice is asking, is the factor impacting uptake with the vaccine also because it's stored frozen? So either Daryl or Joshua, feel free to take this one.
I can speak to some of the many factors that impact uptake. And I think a lot of it is not related to characteristics of the vaccine itself, or known characteristics, and certainly not necessarily physical characteristics. I think a lot of it really is social, behavioral, psychological, clinical. We know that vaccine hesitancy is a thing. It's been amplified, of course, for all kinds of reasons that we're all super aware of since the arrival of COVID. Uptake and interest was very, very high right when this was in the news. And here in Toronto, I can say that, it was virtually impossible to get a vaccine appointment. Many people were complaining when it was front and center in the news for several days just a few weeks ago. But I do think that some of that enthusiasm wanes over time. And there are many folks that I've encountered clinically with whom I've had long, thoughtful conversations with where it's not entirely, a decision that's based on rational reasoning in the way that us as clinicians and public health practitioners, I can say wish it were for folks. It's complicated. There's reasons that are complex related to medical mistrust and structural inequities that exist in our society that mean that people are hesitant for lots of reasons. There's also very real reasons with respect to distribution and access, which are real. So I think it's multifactorial, as are so many such issues.
Thank you so much, Daryl. Anything to add to that, Joshua? I saw that you're prepared to answer Jennifer's question live as well.
Yeah, nothing really to answer. I think that was a great response. can take Jennifer's question as best I can. So Jennifer's asking about the evidence for sexual worker risk in Canada. It's very limited. The epidemiology data for mpox infections in healthcare worker, or sorry, in sex worker risk it's limited. We don't really know too much, and at least at the time of NACI review, there weren't any reported cases in sex workers, at least not in the scientific literature. But we can assume at least that it's being probably drastically underreported. And the overlap in many of these communities is pretty large. So I can see Daryl wants to add in. But the overlap is pretty large, so we can assume risks are at least somewhat similar.
Yeah, thank
Yeah,
you.
I would totally agree with what you just said, Joshua. And you know, what I can add anecdotally is that certainly among GBM people who engage in sex work, we absolutely have seen cases. So it's a thing, of course, not unexpectedly. I think it's also really important for us to recognize again the broader context. Sex work is criminalized in this country. Therefore, as Joshua says, that there is tremendous underreporting, and because we wouldn't expect people to feel confident disclosing this when the structures around them say that the behavior is criminal in nature. So we don't have great data. I suspect that part of the question is also interested in understanding risk in heterosexual sex work. And you can just look at the EPI to see that the number of cases in people assigned female sex at birth is tiny. So I don't know that we've got data on the extent to which those individuals also happen to engage in sex work or not, but certainly it does look like overall the risk we would expect it to be there. It's certainly present in networks of GBM. The extent to which it's true for heterosexual sex workers in this country, I think, is unknown. It's certainly a factor in the expansion in Africa.
Thank you so much, Daryl and Josh. So I know the Public Health Agency of Canada recently published a rapid risk assessment. One of the main questions they explored was the risk of importation, particularly of clade 1A and 1B. And it was stated in that risk assessment that there's a higher risk of importation of clade 1B compared to clade 1A. And we know that clade 1, a lot of cases have been observed in children. So one of the questions that came in is asking, what are some considerations for a pediatrician working in an urban center, either in Ontario or in another urban center across Canada? So I'll pass that to Dr. Tan first.
It's a really great question. I think the key things to remember are that at this time, we have not observed clade 1 really outside of Africa, except for that single case reported in Sweden, that single case reported in Thailand so far, right? So sure, is it possible? It's possible. Is it likely? It is not likely. So I think that is an important place to start. The second place to start is, of course, it's great that folks be vigilant. We should always be wondering about this. And so a careful exposure history, a careful travel history is going to, in the vast majority of cases, be able to eliminate the likelihood that that's the case. We certainly, at the beginning of 2022's outbreaks, observed many cases of hand, foot, mouth, many cases of varicella being diagnosed in mpox consultation sessions, which is reasonable at the beginning, but perhaps I think we've learned enough to now be able to better distinguish it. And varicella is much more common. Hand, foot, mouth is much more common. So think of the common things. If someone does have the right exposure risk, they really have been in an endemic area for clade 1. And remember, many of the cases are reported from more remote areas of those countries. It's not an even distribution across DRC or Kenya or Burundi even at this time. A careful history is going to be helpful, and certainly referral to a local infectious diseases specialist in pediatrics might be appropriate. Thank
you so much, Daryl. And I see, Joshua, you've already answered the question about expanding eligibility. So I think because we're very short on time, we will wrap up there. So thank you again to Daryl and Josh for joining us today with your presentations. Very informative. Thank you so much. And thank you everyone who was able to join us today for this webinar. Just a reminder that the recording of this webinar will be available on the NCCID website under the webcasts tab shortly after the event. And a short evaluation for this webinar should pop up immediately after this event. And we would really appreciate it if you could fill that out. It'll help us with planning future events like this one. So a huge thank you again to Daryl and Josh for joining us today. For participants, please email us at nccid@umanitoba.ca if you have any unanswered questions. And thank you again, and I hope everyone enjoys the rest of your Friday.
Thanks so much.
Everybody.